Welcome everyone to today's webinar. I am Ayla Ellison with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the recording to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Mike Hill is an Assistant Vice President of Information and Analytics Services at Carolinas Healthcare System. Mike has responsibility for all revenue cycle and health information management information systems at Carolinas Healthcare, which is an academic healthcare system that includes over 40 hospitals, 7,000 licensed beds, 900 care locations, and 60,000 employees. Mike has 22 years of IT leadership experience, with the last 11 years focused on healthcare IT. Our second presenter is Tom McDermott, and he is a 20-year veteran in the technology industry with 17 years working to improve security within healthcare systems. Over the past 15 years, Tom has helped build Imprivata into a worldwide technology company with a focus on improving clinical workflow, patient satisfaction, and overall patient safety. During today's webinar, Mike and Tom will discuss industry statistics on patient misidentification, root cause of patient misidentification, clinical and financial consequences, how to improve patient identification processes, and potential solutions for patient identification. Tom, I'll now turn the floor over to you.
Great, thank you, Ayla. So today, patient identification is a manual process and can result in significant safety concerns and revenue loss for your healthcare organization. We're seeing our customers struggle with the following issues. And we're covering over 1,700 customers, so we've been able to get quite a bit of information from our customer base. The first issue is medical errors, which is the third highest cause of death in the United States. 30% of medical errors, such as radiation, blood transfusion, and medication errors, are the result of patient misidentification. One of the root causes of patient misidentification are duplicate medical records and overlays. Duplicate medical records account for 7 to 10% of all medical records and cost up to $1,000 per record on duplicate cleanups. Overlays are more serious and cost up to $5,000 per record to clean up. For the revenue cycle team, revenue loss from denied claims is a huge concern. We found that hospitals lose up to 5% of their annual net patient revenue due to denied claims and bad debt from misidentification. Identity fraud also plays a large role in patient misidentification through stolen identification cards and shared insurance cards presented at the time of registration. An estimated 2.3 million individuals were impacted by medical identity theft in 2014, and this is on a 20% rise year over year. I think, Ayla, we have a polling question before we move forward with some Ponemon Institute numbers.
Yeah, thank you, Tom. I'm going to go ahead and launch a poll question that you will see pop up on your screen. Please go ahead and select one of the following options. We are asking, is patient misidentification a problem in your organization today? Please select one of the following. We have major problem, minor problem, not a problem, or unsure. And we'll just wait a few moments here while we collect responses. Okay. And looks like our results show that 26% said major problem, 35% said minor problem, 14% said not a problem, and then 25% said unsure. Thank you, Tom. I'll go ahead and turn it over back to you.
Absolutely, and those numbers are pretty consistent with the information that we've gathered over the last couple of years as well. So for everyone out there, you're not alone as far as some of the challenges that you're incurring today. The next piece, and let me just progress my slide here, is recently we did a Ponemon Institute conducted a study of clinicians and CFOs on the impact of patient misidentification. Over 500 respondents cited serious concerns around misidentification, its causes, and its consequences. It's interesting. First, we asked the clinical audience what caused patient misidentification. Alarmingly, incorrect ID at registration was the #1 cause. What's interesting is we asked the same question of CFOs and got almost the same answer. Incorrect ID at registration was the #1 cause of misidentification there as well. When you dive deeper into the reasons misidentification happens, respondents cited that having a hard time finding the chart for a patient and finding duplicate records were the top 2 reasons. And this really resonated with me. 86% of clinicians witnessed a medical error from misidentification. This is something that has really resonated and something that we see on a pretty regular basis from our customers as well. 77% of those respondents agreed positive patient identification through the use of biometrics could improve the identification and reduce overall adverse events. On the finance side, 35% of denied claims were the result of patient misidentification. This could be due to technical or demographic errors being sent to the insurance company, a case of identity theft, or simply submitting the wrong patient. This same group agreed that positive patient identification could improve cash flow, reduce denied claims, and even reduce days in the accounts receivable. So I think, Ayla, we're up to polling question number 2.
Wonderful, thank you. Well, you'll go ahead and launch our second polling question, which is asking, what is your organization's duplicate medical record rate? So go ahead and please select one of the following. We have A, over 10%, B, between 8 and 10%, C, 5 to 7%, or then D, less than 5%. And we'll go ahead and just give our audience a few moments to select their answers here. All right, and we'll go ahead and close the poll now, and let's see our results. Looking like 8% selected over 10%, 9% are saying 8 to 10%, 22% selected between 5 and 7%, and 61% is saying less than 5%. Tom, I'll go ahead and turn it back over to you.
That's great. So now what I'll do is let me introduce Mike Hill from Carolinas Healthcare, and we're going to have Mike talk to some of their experiences with their investment in positive patient identification.
Thank you, Tom, and good afternoon. So again, my name is Mike Hill. I'm an Assistant Vice President with Information Services at Carolinas Healthcare System. And just wanted to take a few minutes to talk about our implementation of positive patient identification. And for us, that was implementing a solution involving palm vein biometrics to perform that positive ID. But before we jump into our implementation of the technology, just a couple slides here just to orient you to Carolinas Healthcare System. So we are a large comprehensive healthcare system. We have over 60,000 employees, and we are the second largest public not-for-profit healthcare system in the nation. A couple other statistics on the slide there. Tom, could you advance the next slide, please?
Absolutely.
And here's where we are. So we are centered around Charlotte primarily, but we have care locations in a footprint that really spans across all of North Carolina and into South Carolina as well. Next slide. And then on this slide, just wanted to highlight a couple of things just about, you know, kind of our story is really to provide that integrated care. So we have a deep, you know, breadth of services across the full continuum, and that becomes important in our implementation of this technology because one of the things that we saw as it was an opportunity to really connect all these points of care, whether it's in our ambulatory practices, including our urgent cares and our EDs and our hospitals. So a wide breadth of services that we wanted to connect through this solution. And so I mentioned I'm an IT guy, so one of the things that I like to start with is just a little bit of a picture of our systems environment or technical environment. And I've simplified this view to really point out some of the key technologies that kind of are relevant to patient identification in our environment. And that really starts with our registration systems. So today we do have 3 primary registration systems in our environment. The McKesson STAR for many of our hospitals, EPIC for several of our hospitals and our ambulatory clinics, and then we have a footprint of GE Centricity Business, or also known as historically as IDX, in many of our ambulatory practices. So from a registration standpoint, we are managing those 3 systems. And then for Enterprise Master Patient Index, we use the IBM Initiate product there. And these systems all feed our electronic medical record, which we have Cerner across our full continuum. So all of our acute and ambulatory spaces kind of have that longitudinal record via Cerner. So what were and are our challenges with patient identification? I really start back about 10 years ago, where we were in a situation where we were managing a large patient index. So we had 5.8 million patients in our EMPI, and I also mentioned that that's across several different registration systems. And this was resulting in a duplicate medical record rate of about 5% at that time. So, as Tom mentioned, if you look at industry averages, that's still lower than the average, but certainly higher than we want to be. And what we were experiencing was that as our system would grow and we would acquire new practices or have to integrate new systems, that challenge grew with it, because every time you'd have to do that, you'd go through a process of managing and combining those duplicates, which was making it difficult for us to keep that duplicate medical record rate in check. And then, of course, we were reliant on manual processes for patient identification. So there was a lot of effort into training and accountability on those front end staff, and that exists today. But we were really relying on those manual processes. Next slide, please. So with patient registration, there are a lot of challenges here highlighted on these bullet points, and I just wanted to hit a couple highlights. So one is just it's easy for that information to become outdated in our registration systems as patients move from place to place, or they provide different information depending on the care setting. I think the other point here is that registrars and front desk staff have a very difficult job. They're trying to choose a single patient out of millions of records. They're given limited information in some cases. and sometimes they're asking these questions in public spaces where it might not be completely private. And of course, there's that time crunch. So it isn't surprising that some of these variables come into play where there can be some communication gaps. As far as risks associated with misidentification, just to highlight a couple here, and Tom hit on some of these as well. If you have duplicate records, for us, creating a duplicate in any one of our registration systems creates a duplicate in our EMPI, which then results in a duplicate in our EMR. So it's kind of all cascading, and that basically presents a clinician with an incomplete or inaccurate record, which is a patient safety concern. And that this was primary and for our motivation to do something about it. It was the patient safety aspect. There are other risks having to do with just the registration and trying to make that a more streamlined approach to allow that check-in to happen faster and create a satisfied experience there. And then we also had the costs that we were incurring to just kind of keep that duplicate medical record rate in check through all those activities I mentioned before. As far as impacts to revenue, certainly errors up front in the revenue cycle impact the back end of the revenue cycle. I think this can result in claims denials. It can result in rework. It can result in cleanup efforts, and in some cases privacy breaches if that bad information gets out to the wrong patient. So now let's talk a little bit about some solutions, what we can do about this situation. And so for us, the idea was that if we could attach a patient's biometric data, something that they always have with them, it's basically a part of them, and we could make that link to the patient, to that unique EMPI number or patient record, then once you make that link once, then it's repeatable and it takes some of the human element out of that registration that happens each time. It would improve the overall registration experience, eliminate the duplicate and the overlays. And then there's the additional benefit of deterring kind of ID theft through somebody else trying to use that patient's medical record. When they see that biometrics are being used, that will be a deterrent for somebody to use that approach. When we started down this path, we actually considered several different technologies out there, and palm vein biometrics is one of them. There are other technologies like fingerprint and iris scanning as well, and I think they each have pros and cons associated with them. But for us, when we looked at palm vein scanning, a couple things really came to mind. Number one, it is an extremely accurate form of biometrics, and it's the vein pattern that is used in the palm is really set right at birth and doesn't change over the course of someone's lifetime. So as time goes by, that vein pattern is very consistent and it gets a very high accuracy read. And virtually 100% of the population, most of the population, there are some exceptions, but most of the population, this is an accessible and easy thing for them to do, to put up their right hand onto a device and be scanned. In most scenarios, that is something that would work for the patient. And then from an adoption standpoint, the process is not intrusive at all, and there isn't that stigma associated with, if I use fingerprints as a for instance, there's a bit of a kind of association with fingerprints to law enforcement, and so we felt like some of that feeling would be removed with the palm vein scanning technology. So we did move forward with that. So I wanted to, on this slide, talk a little bit about some of the elements of the way we've implemented patient secure in our environment. I mentioned before that we have multiple registration systems. So in our case, we do have integration with patient secure in our McKesson STAR environment, as well as our GE Centricity business environment and our Epic environment. So really flexible in terms of how the system integrates into those registration systems. And that was important for us for it to be interoperable across all of our care settings. One of the things that we really saw the value in doing this was to make sure that same palm vein enrollment and you just have to do it one time, and it would work whether the patient presents at the ED or at the urgent care or at their primary care physician. It should be seamless and transparent, even if they're working, from our standpoint, they're on different systems, but it all kind of gets tied together through Patient Secure. I mentioned a couple times the points of registration. So that's where we've really implemented this. There are other ways to implement Patient Secure in some clinic, kind of more of the clinician scenarios. But for us, it was getting this technology at the point of registration, at all of our points of registration. We've even implemented it in some on some mobile carts. We have some registration processes that require more mobility, and it's not as static or stationary, and we've successfully deployed it in kind of that mode as well. As we were rolling this out to the public, we also did some kind of campaigns for patient adoption, a way to highlight the program and the benefits in community events, and have an area where people can come by and just enroll and learn about the system. And we felt like we got some positive press in the Charlotte area back when we were doing this, and kind of created some interest from our population as well. One of the things we haven't talked about, but is another patient safety benefit of this technology, is there's also the ability for, if a patient has previously enrolled into the system and they present to the ED, or in this case would be brought in through an ambulance, and they're unconscious, they might not have identification on them. The system does have the ability for you to scan the palm of that patient, and if they've been previously enrolled, it'll bring them up, and you'd have the ability to get to their medical record, whereas prior to this technology, that wouldn't have been the case. Want to mention self-service kiosk support. We're fairly, we're just getting started with our use of self-service kiosks. We are using them with our Epic rollout, using the welcome kiosk, and that was one of our prerequisites, is to make sure that our Patient Secure program would be part of those kiosks, so that patients that have enrolled can easily put their palm up, scan in, and it would pull them up, and they can check themselves in. So we have successfully integrated that into our environment as well. And the final component here, reporting and analytics. This is important for us just because as we're rolling out these programs, and we need the ability to just monitor adoption and monitor compliance to kind of our standards. We definitely pay close attention to the reporting that we get out of the system. Next slide, please. I want to talk a little bit about best practices for implementing this technology. I've mentioned a couple of these, but I think it's worth highlighting. Organizational commitment. Really, in terms of a program like this, really isn't an IT program. It's actually quite easy to roll out the technology and to integrate the technology. Kind of the more challenging things really is more the people part of this, is making sure that there's good understanding of the goals for rolling out Patient Secure, and to make sure that the frontline staff, that you get good buy-in from all your points of, your patient registration teams and, your clinic front desk personnel, to really sell the benefits of the program and to present this option to patients. And then monitoring usage and setting goals. This is important as well for us. It is an option for patients. It's encouraged for them to enroll and to use this technology. It is not required. This isn't going to stop you from being seen at any of our care settings. But with that, because it is kind of an optional component, being able to monitor the usage of the system and really kind of set goals to make sure that the program is being introduced and being adopted, it was important to us, and I think it helped us succeed with this. I mentioned our approach of deploying it at all of our points of registration. I think that's important because you really do see the benefit of this technology when you're using it across that continuum. You don't quite get this value if you're just going back to the primary care physician's office. I think there's some value, but if you're palm scanning into the same place over and over again, they might know your name, and it almost seems like, well, you're not getting the value out of it. But when you kind of take a step back and say, well, that same patient could go to urgent care and ED, various specialty offices, and have that consistent experience and consistently pull up that patient, that's where we've really seen a lot of the value. Integrate with all your registration systems, your EMPI and kiosk, I mentioned that. And then just patient awareness. We've been able to, create brochures and signs and really promote the campaign. And our patients have seen this as a real win. And it's now really an expectation if you come to Carolina's healthcare system that you'll have an opportunity to scan in. Next slide. And this is, our results. I mentioned at the very beginning that, back when we started down this journey, our duplicate medical record rate at 5%. And, we've really focused on this. And I will say, part of getting that down to 0.1% was this program, but a lot of it also is making sure you're equipping that your registration staff with all the tools that they need, and the training that they need, and making sure they're getting that support. But this technology, we believe, is center to how we've been able to keep and maintain that low medical record duplicate rate. And just the quality and consistency at the point of registration, just providing that experience of palm scanning without having to provide a lot of personal information at the point of registration, and being able to just use biometrics. We think it's a patient satisfier as well. And then preventing ID theft and insurance card sharing. We definitely have some experiences where we know it has deterred patients from doing that. So we see that as a benefit. And that concludes my portion.
Great, Mike. Thank you thank you, Mike. That was great. I mean, as a very large customer and an organization that is as large as Carolina's Healthcare, and what you've been able to accomplish with the technology has been really a staple, I think, across the industry. So thank you very much. One of the things we want to continue with is some questions. So we have enough time for the audience to ask some questions. So I think we'll open it up to our moderator.
And thank you, Mike and Tom, for that fantastic presentation. And we will now begin today's question and answer session. So just as a reminder, please submit any questions you have by typing them into your control panel in the space labeled "Enter a question for staff" and clicking send. We will try to get through as many questions as we have time for. We've already had several questions come in, so we'll go ahead and jump in with those. And the first question is, what part of your misidentification are registration errors?
Mike, that's probably more towards you.
I think I don't have, statistics with kind of that breaking down, but, generally when we look at our duplicates, in one form or another, it is a registration error. Because for us, a registrar can see the full EMPI when they're looking the patient up. They may not have been given all the information, but ultimately, kind of the responsibility of the registrar to pick the right patient there. So, I mean, I would say the majority of those errors would be categorized as a registration error.
Thank you very much. And moving on to the next question, it is, with your Initiate EMPI, why is the duplicate medical error still so high at 5%?
Well, I would say that, it hasn't been 5% for some period of time now. When I made that 5% statement, it was back at a period of time where we had the multiple registration systems, which we still do today. We were just standing up Cerner. This was back 10 years ago. We'd introduced Initiate, and we realized, hey, we have a 5% duplicate rate. What are we gonna do about it, basically? And through steps such as implementing this, we've been able to get it down to 0.1. But part of the challenge was when we have multiple registration systems. We had some occasions where people would just I guess they would kind of think of their own practice in a vacuum and not really consider, the impact that, that good search routine would have on the rest of the organization. But we were able to improve that, significantly once we got Initiate into place and realized how big of a problem it was.
Well, thank you for providing that clarification on that. And moving along to the next question, is it possible to utilize this at the bedside?
I can jump on that. So absolutely. We have a number of customers, and I believe Carolina's is included in that, in which we have the palm vein scanners on wireless carts, mobile carts. So absolutely, the palm vein scanner simply just has to be attached to a PC and have access to the registration system. So there's absolutely nothing prohibiting customers from using this at bedside.
Great, and thank you. And the next question is, how are the devices cleaned, and is there a cleaning solution recommended?
Yeah, great question. So we get that quite a bit. What most of our customers do is they'll simply wipe it down with an alcohol swab, either prior to the next patient coming in to register, or they'll just do it immediately after a patient comes through. So let's just say there's a gap between one patient and the next patient. The registration person will simply wipe it down with an alcohol swab. We also find many of our customers will have the gel right there too, for patients to either clean their hands before or after registration.
And Tom, I'll mention that's exactly what we do. One of the things that is worth noting, I think, is a benefit of the palm vein scanning is the contact that the patient makes with the device, the palm resting on the device, it's just contacting plastic. That's very easy to wipe down. The actual, I guess you'd call brains of the device, or the camera portion, is actually set, several inches below the palm. So you're not actually making contact with that lens, or that kind of more sensitive piece of the technology. So I think that helps with wear and tear. You don't see instances where the cameras go bad because they're really not coming into contact with anything. And then the plastic, of course, is really easy to wipe down.
Well, great, that's helpful to understand. And the next question that came in is, how long do you estimate it will take for your existing patients to get their records associated with their palm print?
So, Mike, you can take this. Let me maybe kick it off, and then I'll defer to you. So what we typically see is for the first sort of 6 to 12 months, the organization is typically enrolling their patients. So let's think of it as sort of a hockey stick with enrollments. And then what typically happens is that around 12 months, and certainly this could differ between organizations, it tends to flatten out, and then there are a lot more identifications. So there's the enrollment for a portion of time, obviously, to get people into the system, and then that flattens out, and it tends to be more identifying the patients because you've created a mass within the database. And certainly, again, that can vary depending on organizations and how distributed the palm vein scanners are. So obviously, the more places they're distributed, the more apt that you're able to get not only people enrolled, but people coming back and being identified. So, Mike, you may have your own comments on that as well.
Yeah, no, I think that's a good answer. And for us, with as kind of large and as big of a footprint, and places like urgent cares and EDs where you may not have a very consistent population that's coming back, you'll see a lot of new patients. It's always a part of our program to ask to enroll if they haven't already enrolled. But to your point, that initial 6 months, 12 months, it's going to be heavier on the enroll side, and then it does flatten out, and it becomes more just the authentication component.
Well, thank you both. We have a lot of great questions still coming in. And the next one is, What is the technology background for the palm vein recognition? Is it US or X-rays?
What was that again? US or?
Or X-rays.
X-ray. So it's definitely so I think as Mike mentioned earlier, the technology itself was developed by Fujitsu. It was developed in Japan. In Japan, the most common use is in ATM machines. There is also the use outside of healthcare in a variety of industries. Sometimes it's physical access, financial services. This is, from a healthcare space, this is something that has been going on for the last about 10 years with palm vein in healthcare, and it's been driven by the combination of Fujitsu and Imprivata.
Thank you very much. And the next question from the audience member is, if the greatest challenge in accurate registration is the registrar getting the correct information, how are you assuring that the right person is associated with the palm scan?
Sure. So the important aspect of this is when you're first enrolling a patient, you certainly want to have that correct information up front. So that's either a state, local, or national identification. It could be everything from a passport to a license. So you want to make sure that you are doing the best you can as a registrar to verify that you have the right patient in front of you. And then at that point, you enroll them in the system. The great thing going forward is now you don't have to ask for that information. You're simply asking for the patient to place their palm, provide a date of birth, and it brings it right to that record. So again, the key here is on initial enrollment, asking the correct information, getting the right credentials, and then enrolling the patient. And now going forward, the amount of information you have to ask that patient is very minimal. Really, it's date of birth and the palm.
Great, and thank you for that insight. And the next question from an audience member, they want to know what the percentage of patients is that do not want their palms imaged.
So and I'll let Mike talk specifically to Carolina's. As from an Imprivata perspective, we're getting about 98 to 99% enrollment by patients. It's really interesting because on occasion when we do a new implementation, the registration folks can be, sort of on the negative side. They initially think that, hey, patients don't want to do this. And what's great is it's been the complete opposite. Adoption has been very, very good. Patients really like it because once they understand what it's all about, it's really ensuring their safety, it's ensuring accuracy, making sure that they're being tied to the correct record. There's very little pushback on enrolling in the system.
Our experience has been, as Tom said, the adoption is high. We've seen about 3 to 4% that will elect not to participate in the program. And I'm glad this question was asked, though, because I may have mentioned this, but I think it's worth just making the point again, if I didn't hit it strongly enough the first time. A big part is really at the front end, at that point of registration, having a good, well-crafted script. We found that registrars can be very effective if they have a well-crafted script on how to introduce the program, and in very few short, succinct words, highlighting that this is a program to their benefit for to ensure that the right patient, that you're getting the right treatment and you're the right patient. That goes a long ways towards that adoption, because the harder part is just making sure people understand that this is a benefit to them, and then they'll agree to do it.
Great, thank you so much, Mike. And this question might be a good one for you to address as well. and it is, how much did instances of ID theft go down after implementation of the palm scan technology?
Boy, that's a great question. I wish I had hard data. There's certain aspects of this program I wish I had better data, kind of cause and effect. All I really have to go on is things that we heard back when we'd circle back around with practices and registration areas where we had people actually say that that they know, because they actually had a conversation with the patients, that they were going to use somebody else's identity, but they didn't. You wouldn't think you'd ever hear that, but we had heard instances of this occurring where patients chose to go a different path when they saw the technology in place. But I don't have hard statistics on that one.
I know we have other customers that have definitely seen it as a deterrent. We have some customers in like states like Texas that have definitely seen less, I would consider, identity theft after they put in place the Imprivata patient secure system, because I think what people do is they see people putting their hand on the palm vein and instantly think that, okay, they've incorporated some security measures here. I'm going to have a difficult time trying to use someone else's ID, and they'll go down the street to another health system.
Thank you so much, both for your responses. We still have a lot of great questions, so we'll move along to the next one. And it is, when getting biometrics done, it takes a couple of attempts if people have sweaty palms or fingers. Is that a concern with your palm scan, and has the scan been a little time consuming?
No, what's great about the palm vein, unlike some other forms, certainly, fingerprint sometimes can have some issues if you have really dry hands, or if you just came in from cold temperatures. With the palm vein, because you're not placing your hand on the scanner exactly, there's a gap between the palm vein and the actual camera. It really doesn't matter if your palm is sweaty. In fact, we have situations where folks have come in and they've had a tattoo or a scar on their palm, and that does not affect the quality of the enrollment. So for enrollment, it's simply placing your hand on the palm vein twice, just the first time, and then it's matching it up the second time, and then you're done.
Thank you very much. And our next audience member would like to know, or would like for you to discuss your experience with using this technology in a pediatric population.
Great question. So what we typically recommend is ages 5 and above in a pediatric environment. We find that, and again, this can vary. I mean, you can have a 3-year-old that's, the size of a 5-year-old and they have no problem enrolling. But you may have a 5-year-old that's quite small and may have an issue. We kind of go with about the age of 5 to enroll pediatric patients. And one of the things we're doing now is we have a large enrollment happening up here in the Boston area at Boston Children's Hospital, which is, obviously one of the most prominent pediatric facilities in the country. So they're enrolling and they're rolling out the system as we speak. So I know we have a tremendous amount of interest from quite a few standalone pediatric hospitals as well.
Great, thank you so much. And this next question is, do you use a patient master number and have separate numbers for each location that you all have, or is your system set up for just one overall number?
So I think Mike talked to this a little bit at Carolinas. Yeah, Mike, I'll let you kind of talk to that because you can talk specifics.
Yeah, and that it kind of gets more into what our EMPI solution does, because within our different registration systems, we do have, system-specific identifiers that get generated, but our EMPI solution kind of ties those all together so that basically, if I look at Mike Hill, myself, in the system, I'll have one EMPI number, and then the EMPI solution ties all the other numbers together. And ultimately, it's that master patient index number that we use to associate the palm vein scan. So I know that probably sounds a little convoluted, but ultimately, our master patient number ties the rest of our registration numbers together, and that master patient number is associated with the palm vein scan.
That is very interesting, and thank you for your insight on that. We still have several questions, and we're going to try to get through as many as we can. So moving along to the next one, it is, at what stage of the patient journey is the patient misidentification the biggest issue in your experience? Does registration accuracy help in the time of treating the patient?
Mike, I'm not sure if that's a better one for you or for me. I guess I would think at any point in time, having the accurate patient record matched to that patient, one, it will accelerate the speed in which that patient can be treated. Certainly, here's an example. A patient comes in to the ED, they have no identification, they go ahead and do a quick reg. It could take a considerable amount of time to track down that patient's information if they're not enrolled in a system like Patient Secure. The danger of that is certainly if they have some allergies to certain types of medicine. There's, if they have, high blood pressure, pacemaker. I mean, there's all kinds of scenarios in which you could have put the patient in danger because you don't have the correct information in front of you from a clinical perspective. So certainly having something in place like this will certainly speed up the ability for a clinician to treat that patient.
Great, thank you so much. And it looks like we have time for a few more questions, but I just wanted to mention before we move along that all of the questions will be answered if needed, even via email. So we're just going to try to work through as many as we can during the session now. So the next question is, what is the average roll-around time for implementing the Imprivata biometric system?
So what we're seeing about 90 days, and again, this can vary. Certainly, part of it varies on the availability of resources within the customer organization themselves. What's nice about Patient Secure is it's actually a very light lift from an IT perspective. It's very easy on that side. Really, the predominant amount of work to roll something like this out comes more upon simply the training of the registrars, making sure that the registrars are trained, as Mike alluded to, having a good script so that there's no questions from the registrars. They're simply, following a script. And again, we have found tremendous success when the registrars are all sort of on the same page. The enrollment has been very good. So to answer the question, typically I give 90 days from signature of a contract to really probably going live in a test environment. And most of that time is not the physical setting up the system. It's really probably getting the parties together, the project management team, scoping out the locations that they want to first go after and implement, training the personnel, that type of thing.
Great, and we have time for one more question. And Tom, this is probably a good one for you to answer. And it is Carolina's healthcare system the only organization using this technology? And what are the plans to implement across the country? What is the business model to access and leverage?
Sure. So, fortunately, Carolinas is not the only customer utilizing this system. Would be in big trouble if that were the case. Carolinas was our very first customer, and certainly has a significantly large database of patients enrolled in their system. However, we are rolled out across the entire country. I think now we're in well over 250 different locations across the country, and that makes up, health systems plus their additional locations. So, as an example, Carolinas has, and Mike, correct me if I'm wrong, I think you're 40 plus locations, when you're talking about ambulatory and acute. But we have some very large customers. I'll throw a couple of them out, places like NYU Langone, New York Presbyterian, Maimonides, Scripps and Sharp on the West Coast, Advocate Health, Memorial Hermann, Texas Health Resources, Parkland Health. So, I mean, we run the gamut from every organization that has, 200 beds on up to organizations that have thousands of beds, and many, many locations. So it's certainly a technology that can be used for the community hospital all the way up to the very large IDN across multiple states.
Well, thank you so much. And unfortunately, that is all the time that we have for today. But I want to once again thank Mike and Tom for their excellent presentation and to our audience for participating today. Please enjoy the rest of your day, and we look forward to having you join us in the future for webinars.
Great. Thank you, everybody.